Okay, so can you hear me? Yes?
Yes, yes.
Yes. Okay, so I'm using a microphone. I know we're going over, so I won't belabor the point. We've talked a lot about the DUSIN glide. Here are my disclosures. None are relevant for this talk. So in the late 2000s, like Dr. Tan was talking about, it was all DSEK all the time. There was debates about incision side, pre-cut versus surgeon prepared, refractive effect, etc. And it basically came down to these: insertion, the endoglide, sheets glide, and then the DUSIN. So what we learned then was that the incision side did affect cell counts. The bigger incision was less trauma to the graft, but it had a higher risk of iris prolapse. There were more sutures at the time of surgery, a less stable AC, and could be difficult in complex eyes, especially if they had a lot of PAS. The smaller incisions were nice, but you had more cell loss and trauma. So many publications were done, and they showed low primary graft failure and good cell counts with various methods. There were very few head-to-head trials. You guys showed the evidence of one that's sheets glide against the endoglide, and that showed that the endoglide was better. But there were a lot of papers published that showed good results with many techniques. And so the technique I was asked to talk about is the DUSIN, like Dr. Tiziano was saying. And it's designed in Italy and in France, as we learned. And like many Italian things, it's like the Ferrari of insertion devices here. It looks like a nice place to work there with Dr. DUSIN. And there's various forms we talked about. You have the kind that has the flange that you can manipulate the graft. You have the straightforward kind. You have disposable. And so here's a video from Dr. Aldave, our friend, one of his fellows. And the pros of the DUSIN glide are that you can put it through a 3.5 millimeter incision. It works with anterior chamber IOLs. It works with thin tissue. It helps you to orient the tissue so you don't have to put an S stamp. And the cons are that the forceps are expensive. The glide itself you can get relatively cheap, but the forceps can be quite expensive. But you can reuse them. There's a learning curve. You have to be able to manipulate and hold the forceps with either your left or your right hand. And then you kind of need to use an AC maintainer during the surgery. So again, here's the technique. Dr. Aldave showing us with one of his fellows. You dock the glide into the wound. It's important to maintain so it doesn't get crushed. You bring it into the eye, remove it from the wound, and then let the fluid from the AC maintainer unroll the graft. And then you have to kind of wiggle that forceps there to get it out of the wound. And then you remove the AC maintainer. So basically, there are many variations, but it's kind of an elegant shovel that you can use to invert the graft and use curved forceps to bring it into the eye. So I still do DSEK. I did one last week, and so here's a video from it, and it's basically the preparation and insertion with the DUSIN glide. So this is just our standard Baron has vacuum tree fine. I center the graft, and this was an 8 millimeter one. It'd been pre-cut at the eye bank to around 100 microns. I thought it turned out to be a little thinner. Then I removed it. You can kind of see that rim of stroma underneath. And then what I like to do is I'll remove that extra tissue. And then I'll put, I look at the donor rim to make sure it was cut and that I won't have a thick edge. And then put some viscoelastic over it and kind of bring it onto that flange, kind of trying to touch it in the same place every time so I'm not damaging more tissue. Then under the microscope, I kind of advance it into the glide. So I kind of bring it on here. Those are just Utrata forceps that are present in our DSEK tray. And again, trying to grab it in the same spot and then bringing it up. And then as we all know, this is the endothelium on the inside here. And you just kind of want to get a little edge that you'll be able to grab with the forceps. I'm just kind of demonstrating that under the microscope. And then this was a right eye. So I have the forceps with my left hand. This was a previous trauma with a sutured IOL, and he had pseudophakic bullous. I have the AC maintainer there. And like Dr. Tiziano was saying, you want to grab it outside the eye, then engage the wound, and then bring it into the eye and it unfolds. It can be tricky to dislodge it from the forceps. There I remove the AC maintainer, and you kind of have to open them and wiggle it in order to get it out without bringing the DSEK out through that small wound, which can happen. And then I put an air bubble under it. Then I begin to suture my wound. So I suture the main wound, and then I suture the two paracenteses. This is a vitrectomized eye, so it's kind of unicameral, but there was enough support, as you can tell by the PCIOL there, to form a normal type air bubble in the front of the eye. And so after this, I just sutured it, and then I centered the graft. And so just a brief talk. Basically, my advice is to find your technique and master it. There's a lot of ways to do it, and you can be successful with any of them. I would discuss it with your mentors and colleagues and learn about the different techniques during your training if you're still in training. Practice in the wet lab and then find the right fit for you. They all have their pros and cons, including cost. And so I've seen successful surgery with any of them. And the CPTS study, which was a big study here in the U.S., we all know about. There were 70 surgeons, 1,000 surgeries, and they didn't really find any difference in surgical technique in terms of graft failure. Now, cell loss can be an issue, but in terms of success or failure, you can be good with any of these techniques. So I want to thank you again for your time, and I will stop sharing now.